Assalamu alaikum, everyone. Can everybody hear me? I just wanted to make sure there is not a
Yes,
problem.
yes.
Yeah, perfect. So, on behalf of Academic Neonatology Group of Pakistan and on behalf of APPNA Feeds, we welcome you all to our monthly lecture series. And today I'm really excited and happy and do have a wonderful speaker today, an amazing mentor and leader. So I'm going to start with introduction. So today's speaker we have is Dr. Khalid Haque, and it is my great honor to introduce him. Dr. Khalid Haque is a distinguished neonatologist whose leadership and mentorship spans 5 decades across 4 continents. And he is a fellow of Royal Colleges of Physicians in London, Edinburgh, and Ireland. And Dr. Haque brings a wealth of global expertise to the field of newborn care with over 170 peer-reviewed publications. No kidding, 170. His work has shaped best practices in neonatal sepsis, necrotizing enterocolitis, and evidence-based use of antibiotics. As visiting professor at the University of Child Health Sciences, he continues to guide next generation of neonatologists. Today, Dr. Haque will be speaking on one of the most debated and evolving areas in the field, especially in the context of Pakistan, I would emphasize, on controversies in neonatal resuscitation. And his insight, grounded in research and rich clinical experience, promises to challenge conventional thinking and spark meaningful discussion. Please join me in welcoming Dr. Haque. I know I can speak about Dr. Haque way long, but I don't want to waste time. So I will welcome again Dr. Haque on this lecture series, and I am going to hand over the virtual podium to you, and with the request that if you're not muted, please mute yourself. You can ask questions in the chat box, and we will have question answer session in the end as well. Please go ahead, Dr. Haque. Thank you so much.
Can you see my slides, Safdar?
Yes, we can see. Thank you.
Right. And can you hear me all right?
Yes, we can.
Good. Bismillahirrahmanirrahim. Safdar, General Saab is not there, never mind. But Safdar, you're equally distinguished friends and colleagues. I'm very grateful to Sajjad and APPNA for asking me to give this talk in the monthly sessions. And some of you might remember that at the Indus Hospital Symposium, I talked about the golden hour. So I thought I'll continue with the same theme of management in the delivery room, but with a certain twist. And I will talk about uncertainties in neonatal resuscitation. And the very first thing is the word resuscitation, or should we be saying stabilization? Resuscitation means recovering from the dead, or stabilization means to stabilize somebody in the process. You can choose the word you like, but there is, in fact, uncertainty in the very word whether we should be using resuscitation or stabilization. I have nothing to declare and have no conflict of interest. I have used many of Professor Satyan's slides, and I'm very grateful to him for allowing me to use them. And I've used them also from a lot of his available ones on the net. My learning objectives for this talk are just 3. My talk is really the 3 learning objectives: scope of the problem, just 1 slide, brief explanation of the dynamic physiology, and the current ongoing uncertainties. But remember, intelligence isn't knowing everything. It is the ability to challenge everything you know. Science can only progress when certainties are challenged. And that's what I want to do in the next 45, 50 minutes today. So just to give you a background, in the world, about 4 million neonatal deaths occur every year. Of these, 70% occur on the day of birth. And of these 70%, 99% take place in resource-poor countries of Africa and Southeast Asia. So death on the day of birth for families in the lower and middle-income countries is accepted as a new normal because it occurs so frequently. In Pakistan, Nearly 400 newborns die on the day of their birth. So it is a very truthsome saying that we are never closer to our death than on the day of our birth. Of the 160 million births per year, only 1.4 million require advanced resuscitation. But once again, 85 to 90% of these occur in limited resource countries. And for these 1.4 million who require advanced resuscitation, there are guidelines galore. Every country mostly have it, and we have joined the club too. Now, some people, and there have been interesting WhatsApp chat yesterday and today in our group, some people believe in them to the last word, that they are the absolute final truth. And some people have to practice these guidelines because of medical legal reasons. But the reality is like that most of these guidelines are derived from experimental or experiential evidence from simulation mannequins, animal models, and very few from randomized human clinical trials. Over 65 to 70% of the recommendations are based on expert opinion and consensus, and not based on robust evidence. As you know, expert opinion and consensus is the lowest level in hierarchy of evidence. But that is what these guidelines are based on. And some, I could see in the discussion, absolutely use the word to word and believe in that. And some, of course, rightly have to use them for medical legal reasons. But remember, these are consensus opinion, and hence they are constantly challenged and updated. So for this talk, I will be moving from physiology to practice and discussing the dilemmas in between. I know Junaid is there, and he always says to me, "Sir, aap physiology bahut batate." But I think from a physiological perspective, the changes that occur within the first few minutes during transition from intrauterine to extrauterine life are so profound and so complex that we are unlikely to come across ever again in our life. Hence, clear understanding of these unique physiological changes is essential to form the basis of successful neonatal resuscitation or stabilization, whichever you want to call it. So the basic bringing down physiology right to the crux in just 2 or 3 slides, the two main things that the fetus needs to do to adapt from intrauterine to extrauterine life is that fetus must initiate regular breathing, and they need to get rid of the lung fluid. Why? Because in utero, the baby is blue, the saturations are low, the pulmonary resistance is high, and the cardiac output is low. And within a few minutes, it is expected that the baby will become pink, have a higher saturation, the pulmonary pressures, resistance will fall, and cardiac output will increase. Now, this is an important, very great shift and a very complex mechanism, but we'll try and simplify it in just these two main things, how the baby tries to prepare itself and achieve the goal that is required. So for the first task, that is preparing to establish regular breathing, because survival after birth is not possible without aeration of the lungs. So the infant needs a mature pontine and medullary respiratory centers and group of neurons, a neuromuscular system, phrenic nerve, chemoreceptors, and the diaphragm. And these are mature in the term and near-term infants. But what about the preterm infant? He or she needs all of the above, but they are not mature. But on top of that, the preterm infant has a soft thoracic cage. And the preterm infant and the infant or the fetus is used to breathing with a closed glottis in utero to keep the lung fluid in so that the lung alveolar growth takes place. So the preterm is not quite prepared to open the glottis and breathes against the closed glottis with a pliable chest, thus makes a grunting noise. And in inspiration, instead of the chest expanding, the chest goes in. And then in preterm infant also has a very strong hearing inhibitory reflex, which prevents the fetus from preterm infant from stretching the lungs and opening the alveoli. So that's the first task, is lung aeration. The next task is to get rid of the lung fluid. In utero, the type 2 cells secrete a lot of chloride ions into the alveolar fluid. And with the chloride ion comes sodium and water. At the onset of labor, there's a surge of fetal glucocorticoids, thyroid hormones, epinephrine, vasopressin, and the oxygen which we give. That stimulates the sodium channel within the alveolar cell and for the sodium to come out of the alveoli into the interstitium. And with the sodium comes chloride and water, and that's how the lung fluid is pushed out of the alveoli and it's drained off in the lymphatics and the pulmonary and by the pulmonary capillaries. Now, this does not happen if you do a cesarean section prior to the onset of labor or in babies who are born less than 32 weeks, because they are unable to generate a surge of the glucocorticoids, epinephrine, and vasopressin, which are responsible for transmission of chloride and sodium in and out of the alveoli. So the cartoon of all that, if I put it all together, the fetus is surrounded in fluids, the alveoli are filled with fluid, with the pulmonary vasculature constricted and high pulmonary vascular resistance. As the baby takes the first breath, and now some people may not recognize this, but the initial pressure of the baby gasping for breath in the first can be as high as 105 centimeters of water, with a mean pressure of 52. But what is even more important is that when the baby takes a deep breath, first breath, then he or she holds it before taking expiration. And that is because the mean expiratory pressure the baby wants to hold is even higher, so that to prevent the lung fluid coming back into the alveoli. And with this gesture, the alveoli open, are filled with air, the pulmonary vasculature dilates, and the pulmonary resistance falls, and the baby starts to establish regular breathing and starts to establish functional residual volume. So this is the process in which the baby goes through. So in summary, lung aeration and ventilation are the central events that set in motion the successful transition by increasing pulmonary blood flow, increasing left ventricular preload, improving cardiac output, systemic circulation, and venous return, so the baby systemic circulation can then start functioning. Aeration and ventilation happen inadequately or slowly in preterm, or babies who are hypoxic or asphyxiated, hindering their cardiovascular and pulmonary changes, which I've just shown you. Hence, these are the babies who need our help. Now, before I come to what help we need to provide, something which particularly in the low and middle income countries, which we don't have much control on, is the environmental temperature of the delivery room. But even in the West today, 4 out of 10 very preterm infants admitted to an ICU are hypothermic. And hypothermia is defined as 36 degrees centigrade or less. And you can see that 28% increase in mortality per degree decrease in neonatal body temperature below 36 degrees centigrade. And this is, in fact, much easier to control if we could, and we will be able to save many lives if we control the thermal environmental temperature in the delivery room. Because if you don't, the mortalities increase, incidence of RDS increase, IVH, sepsis, hypoglycemia, all that increases with, where did my slides go? Increases with hypothermia. Now here again, one of the first uncertainties, what should be the labor ward temperature? ILCOR suggests 23 to 25. WHO suggests much higher. It has a global impact, whereas ILCOR is mainly from the West, European and North American countries. So you can choose what should be ideal for you, but you must make sure that the delivery room temperature is maintained at this level. Please, could you mute yourself? Thank you very much. Now, what we can do, and the first uncertainty is about the umbilical cord management. How, when, and who. Because the risk and benefits of various umbilical cord management strategies affect all the 160 million neonates born worldwide. Now, in the most countries, there is a guideline or the huddle between the obstetrician and the neonatologist, and they determine the strategy. But it's interesting when you look at the umbilical cord clamping strategies. Thor, 600 years BC, stated that the practice of tying and cutting the navel string the instant the child is born has nothing to plead in its favor, but just custom, i.e., Torah suggested no immediate cord clamping, but delayed cord clamping. The Inca Indians of South America, where I have been and seen them and looked at them, for thousands of years have been practicing not cutting the cord till the baby starts breathing. Physiological-based cord clamping. Darwin in 1874 pleaded for delayed cord clamping by saying a portion of blood being left in the placenta which rightfully belongs to the child, i.e., the importance of placental transfusion. Placental transfusion was first recorded by Pierre Boudin, who, as you know, is the father of neonatal medicine. He recorded in 1876, studied the blood left in the placenta. Early cord clamping, 109 mils. Late cord clamping, 17 mils. And the differential was 92 mils. And there you can see that 92 mils, which belonged to the baby, was left in the placenta. So where did early cord clamping come from? From 1889, hospitals in births in UK started. And because they wanted to have a rapid turnover, the obstetric textbooks started recommending early cord clamping. It took about 40 years from then when the obstetricians started to question this practice. And another 70 years for NICE to change its advice, which it only did in 2007, from early cord clamping to delayed cord clamping. We now know from research and evidence that early cord clamping is bad because oxygenated umbilical vein blood stays in the placenta, pulmonary resistance does not fall, left ventricle is not filled, the preload is low, and the blood flow to the brain is reduced. While in delayed cord clamping, the pulmonary resistance falls, the pulmonary blood flow increases, the left ventricle is filled, improving the cardiac output, and about 40% of the cardiac output is provided in the last few seconds of delivery. And this is important, and it is important for babies who are born with congenital phlegmatic hernia or critical congenital heart disease. Even them, they require more blood. And it's fascinating that the current advice is that in CDH and CCHD, the clamp should be clamped immediately. But in fact, the baby has been living in utero, receiving placental transfusion for 9 months. Do you think another 30 seconds or 60 seconds will make a huge difference to these babies? But that is the advice, and we can discuss that later. But the problem is we do not know what the ideal period of delayed cord clamping is. But what we do know, at least in term and near-term healthy infants delivered vaginally, the longer delay, the better. And this is a paper from Anup Kataria showing the timing of the cord is more than 180 seconds in term and near-term healthy babies, reduces much of the morbidity, but more importantly, it provides the stem cells which increase the myelin content in the developing brain, and fine motor development and social behavior at 4 years is much better. So the longer you delay in healthy babies and near-term babies, the better it is. But what about babies who are non-vigorous, who are non-healthy or apneic? Their cord management remains controversial. But what we do know, that it is these babies who require placental transfusion to improve their cardiovascular adaptation. It is these babies who require placental oxygen to help in gas exchange and reduce the pulmonary vascular resistance. It is these babies who need the autologous stem cells that may help mitigate and repair possible consequent brain injury. The current recommendation of delayed cord clamping for these babies is 30 seconds. Is a consensus opinion and not based on robust evidence. But what about in these babies trying to do umbilical cord milking? Because it restores the left ventricle preload, improves pulmonary and cerebral blood flow. But Debate is whether we should give longer than 30 seconds of delayed cord clamping, or should we do umbilical cord milking in these babies. And if we choose to do umbilical cord milking, should it be 4 milks, or we cut the umbilical cord about 20-25 centimeters and then only milk once the umbilical cord has been cut. Anup Kataria, again in his many papers in 23 and 24, compared cord milking versus early cord clamping in non-vigorous infants between 28 and 35 weeks. And he showed a lot of reduction in morbidity, but no reduction in the admission to an ICU or in death. But the cardiac metrics were much better, and other morbidities were much better with cord milking. So to summarize cord milking is non-inferior to delayed cord clamping in babies 28 weeks and above. In less than 28 weeks, and here I have written the 28 weeks in a different color for a particular reason, which will become clear in a minute, is not recommended due to higher incidence of IVH. There are, of course, short-term benefits and no long-term neurological adverse effects of umbilical cord milking. Compared to early cord milking, again, Anup Kataria, doing a dose analysis, found that umbilical cord milking reduces the need for cardiorespiratory support, admission to an ICU, mortality, and mild HIE. Catherine Peterson last year compared between early cord clamping, delayed cord clamping, and umbilical cord milking in less than 32 weeks infants. Early cord clamping less than a minute, delayed cord clamping more than a minute, umbilical cord milking times 4. And what she showed essentially is that all the number of infants achieving the target saturation of 80% in 5 minutes was similar in all groups. But the FiO2 needed to achieve this goal was higher in the early cord clamping. Remember, from your physiology, the higher the oxygen concentration and longer we give oxygen, the greater the chance of it inducing epigenetic change that may have long-term consequences. What about physiology-based cord clamping? This century-old practice focuses on ensuring an infant has established effective breathing, that is spontaneous or helped by positive pressure ventilation, and stable cardiovascular function, reflected by improving heart rate before the cord is clamped. No time criteria is set. Takes how long it takes. So the Swedish workers in 2023 tried physiological-based cord clamping and showed that with physiological-based cord clamping, the heart rate was actually increased earlier than early cord clamping. The saturations were achieved much earlier. The FiO2 requirement was much lower. The brain oxygenation delivery was better, and the mean airway pressure was better. This was confirmed in term babies in low and middle income countries in Tanzania, and where they assessed the risk decreased by 20% for every 10 seconds up to 2 minutes delay in cord clamping after the onset of spontaneous respiration in term infants or near-term infants. In babies less than 30 weeks or 27 weeks, there was no impact on survival, but also no untoward effect. So, after centuries, we seem to have come full circle and rediscovered the benefits of cord clamping after aeration, physiological cord clamping, and the benefits of placental transfusion. Is it time to review the clamping practices? But if you look at the current recommendations, there are 9 bodies with 8 different advices, which vary from 0 seconds to more than 300 seconds. ILCOR does not recommend umbilical cord milking for less than 29 weeks. I had suggested 28 weeks from Anup Kataria's work, ILCOR 29 weeks, and recently Sajjad shared a clip on WhatsApp which said 32 weeks. Interesting. The NICE guidelines also go up to 300 seconds in term infants. The American Academy of Medicine, 300 seconds. The Resuscitation Council, more than 60 seconds, plus physiological-based cord clamping. Similarly, the European Research Council. So there are lots of variations in these guidelines. For non-vigorous infants, Resuscitation Council in UK suggested that if initial resuscitation can be safely undertaken with cord intact, it may be possible to delay cord clamping whilst performing these interventions and consider umbilical cord milking above 28 weeks. They followed the Qatari's criteria. The American Academy of Pediatrics, non-vigorous 35 to 42 weeks intact cord clamping may be reasonable. But going through these guidelines actually gives you a headache. It certainly gave me a headache to try and analyze what I should do in the labor ward. So my take on umbilical cord milking is very simple. You have preterm, vigorous, delayed cord clamping. I do not know the exact duration. Non-vigorous, I would start positive pressure ventilation and do physiological-based cord clamping. Or if the baby is more than 28 weeks, I'd certainly consider umbilical cord milking. In a term vigorous baby, again, delayed cord clamping, 60 minutes or longer. Non-vigorous umbilical cord milking with physiological-based cord clamping. The only time I would do immediate cord clamping is when there is placental abrasion or bleeding. There are many knowledge gaps about cord management. Optimal duration of delay of cord clamping, particularly in preterm and hypoxic and asphyxiated infants. When to institute umbilical cord milking, how many times to milk the cord, what strategy to use for preterm multiple births. Now let's move away from cord milking and come to meconium-stained amniotic fluid, a baby born through meconium. Before 2015, if the infant was vigorous, no stimulation was required. But non-vigorous infants, which formed about 10 to 15%, do not stimulate and intubate them and do tracheal intubation and suction. And 70% of these babies were sucked, but the incidence of meconium aspiration syndrome was about 5%. There was a sentinel paper by Tom Wiswell in 2016, and from that, the American Academy decided to change its advice for non-vigorous infants from 2017, dry and stimulate these babies. No suction, do positive pressure ventilation, do not suck. Less than 2% of babies were sucked, but not sucking led to more babies being admitted to an ICU, more need of surfactant, more need of mechanical ventilation, more need of inhaled nitric oxide, and much higher incidence of meconium aspiration syndrome. A recent meta-analysis in 2023 has confirmed this, that you require morbidity is much higher if you don't do tracheal suction. But of course, at the moment, there is no correct answer, and therefore there is an urgent need for a large randomized clinical trial. Now, changing gears again, coming to oxygen, one of the two drugs which is recommended in neonatal resuscitation or stabilization. Oxygen has been used for more than nearly 250 years. In 1998 and in 2010, ILCOR recommended starting with 21% instead of 100% and titrated to get the balance right. They did not define what they meant by titration. The problem is that we do not know what the right balance is. If we don't give enough, you cause hypoxia. If you give too much, you cause oxidative stress. And it is only now, in the last 6 or 7 years, that we've started to understand the pathophysiology of lung development and its relationship with oxygen. It's a very complex subject, but I tried to put it in one slide. Hypoxia-inducible factor is the master regulator of lung development. It is responsible for alveolar development, and it is responsible for pulmonary vascular development, and also for development of the red cells. But it acts on more than 2,500 target genes. So it's a very complex molecule. But the most important molecules are HIF1 alpha and HIF2 alpha. What it does in the relatively hypoxic environment of in utero, it promotes alveolar development, it promotes pulmonary vascular development and erythropoiesis. But because these are growing organs, they need energy, and they produce waste product from the mitochondria. These are the toxic free radicals and the oxidative radicals, which are produced by the mitochondria. HIF dampens them down too. So it has two roles: developing alveoli, developing pulmonary vascular erythrocytes, and also dampening down the toxic free radicals. Once the baby is born, the alveolar oxygen increases. This degrades the IF-1 alpha, down-regulating its protective effect. And so what happens is that the oxidative stress increases once the baby is exposed to higher alveolar oxygen. Now, in the term infant, with better antioxidant defense system, the term infant can deal with it. But what about the preterm infant, particularly preterm infant requiring oxygen, and they have poor antioxidant defense? What it does, these oxidative products reduce the production of alveoli, reduce alveogenesis, and start pruning the pulmonary vasculature or vasculature elsewhere, i.e., those initiate the first changes of ROP, or earlier preliminary pruning in BPD, PVL, and necrotizing enterocolitis. So despite these insights, there are many knowledge gaps. What is the optimal oxygen concentration that balances the need for adequate oxygenation without compromising HIF? Can we modulate that? And that some work is going on that area. But we, in practice today, nearly 80 to 90% of babies less than 32 weeks or less than 1,000 grams, and some even in term babies receive oxygen in the delivery room to prevent hypoxia to the brain and vital organs, to dilate the pulmonary vessels and improve gas exchange. So we are caught between a rock and a hard place. Hypoxia causes cellular damage and tissue damage. Hyperoxia causes toxic and free radical injury. And this is because oxygen supplementation in preterm infants remains an uncharted territory. We really don't know what is the ideal oxygen. But what we do know about oxygen in the delivery room is that over 60% of mothers in US are given oxygen. My daughter recently, healthy girl, delivered a baby at a level 5 obstetric unit in San Francisco, and she was given oxygen to breathe. I don't know why, but there we are, despite the advice from the American Academy and the Royal College against this practice. The reason being that if you give oxygen to the mother, the possible reactive species and oxidative stress increases in the fetus, and it has an effect on the placental oxygen equilibrium. RCTs have shown no difference in fetal heart rate, like artery gas between deliveries with or without oxygen administration during labor. But old habits are difficult to die. What we also know of oxygen in the delivery room is there are now centile charts created by Dawson in 2010, and which are now followed, and they were the reason to establish the target saturation of 80% in 5 minutes, or 85% in 5 minutes, were derived from the 25th to 50th centile range in these healthy infants by consensus, though the median differed with gestational age. So the evidence for this benchmark is weak to start off with, and to top it all, less than 50% of preterm infants achieve this target. Nevertheless, Julie Uy has showed that the preterm infants less than 32 weeks of gestation who did not achieve saturation of 80% within 5 minutes, independent of whatever oxygen you were giving them, had a higher mortality, more severe IVH, poorer neurodevelopmental outcome. So this standard target was set in stone, so to speak, from there on. The first study comparing low versus high oxygen and titrated oxygen administration during resuscitation came from Canada in less than 32 weeks. They titrated oxygen by 20% every 15 seconds. They had 3 groups. They started with 100%, stayed on 100%, started with 100%, and titrated downwards. started on 21% and titrated upwards. As you can see here, what happened was the high static oxygen group, the red line, achieved the target within 3 minutes, but by 4 minutes it consistently overshot the target, so caused hyperoxia. The low oxygen group, the in gray line here, did not achieve the target until 5 to 6 minutes. The moderate oxygen, that is starting high in the green line and then titrating downwards, achieved the target in 3.5 minutes and remained within the target zone. So this was a sentinel study by Rabi in Canada. But ILCOR and NRP ignored that study, and since 2015, the International Resuscitation Guidelines recommended resuscitation of preterm infants should commence with a low FiO2 in order to reduce the risk of hyperoxia. This initial low FiO2 should then be titrated using pulse oximetry, and I'll have something to say about pulse oximetry in a minute, based on the 25th centile of oxygen saturation targets ranges defined by Dawson. Remember, Dawson centile charts were in the era of early cord clamping. That the folly of this advice from NRP and ILCOR was shown in the very large Canadian neonatal networks, nearly 1,200 babies comparing 100% oxygen with 21 to 40% oxygen in extremely preterm infant. Giving 21% to 40% oxygen increased neurological injury, increased mortality, increased NEC, increased days on assisted ventilation, no change in BPD. This was again also confirmed in 2017 in the Torpedo-2 study, where the mortality was much, much higher when they started in room air for these preterm babies compared to the 100% oxygen to start off with. ILCOR was very perturbed by this, and so they commissioned multiple meta-analyses, high versus low oxygen in the delivery room less than 32 weeks. 3 meta-analyses, 21% compared to 30%, mortality, no difference. Less than 40% to start off and more than 40% to start off, mortality no different. But what Julie Uwe again in her second study showed that 30% versus 60% FiO2 to start off with, the 60% babies achieved the target much sooner than the babies who were given 30% oxygen. Dacre repeated Rabi's study in slightly younger babies of 30 weeks. It started with 100% oxygen compared to 30% oxygen, and he showed that the target was achieved much sooner, and he was able to titrate 100% oxygen very, very rapidly. And this maintained within the target saturation levels described by ILCOR of 85% within 5 minutes. But what is more important, that within this short period of time when the oxygen was given, there was no increase in oxidative stress between 30% and 100% oxygen. Professor Satyan in his lab in his work has also shown recently that better placental transfusion and lung aeration with 100% FiO2 given for just 60 seconds before clamping the cord, because the dilutional effect of PO2 by umbilical venous return prevents the hyperoxia, and he showed that they were able to achieve the target much sooner and maintained it at that level. It gave it 100% oxygen for 60 seconds and brought it rapidly down to 30 seconds. This was also confirmed by a small study by Sidropoulos last year. So to conclude, oxygen, the supplementation at 100% for 60 seconds during DCC can potentially increase the alveolar oxygenation and induce pulmonary vasodilatation without systemic hyperoxia. So more studies are required to confirm this. So please do not go at the end of this talk to say Dr. Haque said starting with 100% oxygen. Do not do this at this moment in time, because there is more evidence is required. What are the current recommendations? Of course, in term infants, start resuscitation with 21%. What about moderate to preterm infants? Initiate with 21 to 30%? We don't know. weak recommendation, very low certainty, evidence only 23% meet the main target. What about extremely preterm infant? Initial oxygen resuscitation is not really known. What about the target? 5 minutes of 80 to 85%, again established when the early cord clamping era and with very few preterm infants in that cohort. The goal of saturation of 85 and 100 and a heart rate of 100 by 2 minutes, less than 50% of preterms achieve this. So what are the gaps in our knowledge of oxygen delivery? One size does not fit all. It's very clear. Should 5-minute saturation targets be the same for all gestational ages? Should they be different? Normoxia in preterm soon after birth remains undefined, and there is 25% variation in the target set by various bodies. Now, the NRP sets the target at 85% at 5 minutes. Europeans set the target at 90 to 95%, and there are some others which set the target in between. We do not know to titrate saturations upwards or downwards. How quickly should we adjust the FiO2? How to measure the saturation? Now, it depends on how the initial measurements were made and what equipment you have. The old pulse oximeters, which use the low noise cable sensor, are they have a 25% difference between the modern pulse oximeters, which use the red diamond sensors, which are much more accurate. So I do not know what pulse oximeter you use, and you have to be careful which one you're using, and so saturation should be monitored accordingly. What is the impact of physiological cord clamping or umbilical cord milking on setting saturation targets? We do not know. Should we be using new saturation centile charts described by Wolfsberger last year in the delayed cord clamping era and do away with the Dawson charts? What are the long-term genetic impact of giving oxygen to these babies? The next question, how do we provide respiratory support? 91% in the world use bag and mask. But there are, of course, great limitations. We all know there's a large variability in mask leak, inconsistent respiratory rate, particularly when there's so much is going on in the delivery room with resuscitation. The attention of the person giving bag and mask is diverted, and recent paper in archives has shown that there is inconsistency in respiratory rate falls, inspiratory time goes up and down, tidal volume falls, minute volume falls because the operator is distracted, and there is, of course, operator-dependent variability. And therefore, TP's equipment is propagated. It has less need for intubation, higher achievement, earlier achievement of saturation. But of course, the baby has to work hard against the TPs when you're imposing the inspiratory pressure. What about how long does it take? Delay in the time taken to changes in FiO2 made at the blender to reach the airway. There's a very nice study titrating FiO2 downwards or titrating FiO2 upwards. Nasal prongs seem to be doing the best, achieving the best and earlier change because of lack of dead space. There is not much difference between bag and mask and neopuff in how soon the actual change is achieved in the baby. Neopuff versus TP's nasal prongs. Again, nasal prongs seem to do better in the requirement for intubation and death within the 30 minutes. Nasal prongs seem to be better than the TP's, and in requirement for intubation, again, the nasal prongs seem to be better. But of course, much larger studies are required to refute or establish the advantages of using nasal prongs during resuscitation. What about alternate pathways? Supraglottic airway, much better if you have them, and you can see the meta-analysis shows it is much better. It reduces, it has less failure, and it has less need for intubation. But of course, there are limitations of the size and the availability and the cost, and I think there is no replacement for using correct bag and mask technique and using Mr. SOPA to improve PPV if you are having trouble. There is a debate about sustained inflation breaths. to give or not to give, as Romeo said. The optimal ventilation strategy immediately after birth for depressed infants with no spontaneous respiratory effort and liquid-filled lung is not known. There are many unknowns. There are potential benefits of better alveolar recruitment, increased pulmonary blood flow, and reduction in PVR. But of course, there are potential harm. Excessive tidal volume may cause lung injury and inflammation and hypocarbia. There is an Atlantic divide. Europeans prefer sustained inflations. North Americans do not. And the meta-analysis showed there is no difference in overall mortality, except perhaps there is a trend in mortality less than 28 weeks. But what we do not know is the effectiveness of sustained inflation on alveoli recruitment, optimal levels of PIP or PEEP for sustained inflation. Current European recommendations of starting PIP duration of sustained inflation are not based on reverse evidence, and within Europe there is 30 to 40% variation between guidelines. So this again remains an open research question. In 2015 marked a paradigm shift in our thinking in respiratory support at birth, shifting from ventilating the lungs. When I was working, we used to prefer ventilating the lungs to supporting spontaneous breathing while simultaneously preventing lung collapse at the end of expiration, providing CPAP. And CPAP has gradually become routine in the delivery room, and it helps. It has many advantages, but also some disadvantages. There is a challenger in the game, and that is the high flow nasal cannula, and it seems to be non-inferior to CPAP in the delivery room. And the meta-analysis showed that there is no difference between respiratory failure whether you use CPAP or high flow nasal cannula, but there is less air leak, less nasal trauma, less abdominal distension. But with CPAP, which is now the standard, we do not know the optimal pressure. If we do not give enough, we leave atelectasis. If we give too much, we cause hyperinflation. The appropriate and the optimal one, which we do not know, and whether we should start with higher pressure and reduce the need. And we have some evidence that starting with higher pressure reduces the need for mechanical ventilation. And this is called dynamic CPAP, which is being propagated by Tingay and colleagues. Step-by-step increase CPAP beyond 5 to 6, going up or coming down. But this is based on very little scientific data. And I'd like to come to the very rare things now, the cardiac compression. What is the evidence? The current guidelines are based on asystolic pulseless animals, pediatric and adult research, as well as feasibility and expert opinion. The current 3:1, 90 cord compression, chest compression, and 30 breaths ratio is based on very low quality evidence. It's come to think of it, the normal heart rate of term infants at birth is between 80 and 160 breaths per minute, and of preterms is much higher, 120 to 180. Should the cutoff for initiating chest compression be the same, i.e., which is at the moment less than 60 breaths per minute for both? We really don't know the answer. Then there is the dilemma that we are dealing with a baby who's bradycardic, not necessarily asystolic, on which the evidence is based. And the effect of chest compression during bradycardia is not known. Given the need for both, the baby requires ventilatory support and end organ perfusion by chest compression, reducing interruptions in the chest compression remains a challenge. And this has been depicted by Dr. Koo and colleagues very nicely in this diagram. We need adequate lung aeration is necessary for successful resuscitation, but excessive tidal volume risks the brain injury and IVH. Chest compression causes air to be expelled out from the lungs, causing loss of functional residual capacity and low tidal volume. Chest compression may help in carotid blood flow, but may impede venous return. An interruption, because 1, 2, 3, and then breathe. We stop chest compression after every few seconds. The interruption in chest compression destabilizes cerebral blood flow and may be the origin of cerebral hemorrhage. So the need to balance uninterrupted fast cardiac chest compression rate with making time for effective breaths remains a challenge. And the other dilemma, which is in fact, I think, far more important to realize from a physiological perspective, ventricular filling and coronary blood flow occurs the peak of diastole, while cerebral perfusion occurs during the peak of systole. Therefore, performing asynchronous chest compression may interfere either with coronary blood flow and impair ventricular filling or cerebral blood flow. So the optimal compression to ventilation ratio in the newborn is yet to be determined. Continuous chest compression with asynchronous ventilation at a chest compression rate of 90 to 120 minutes, ratios of 2 to 1, 4 to 1, 15 to 2 are being explored, and we do not have the answer available just yet. One strategy which has been propagated by a small study is chest compression plus sustained inflation. Sustained pressures of 25 to 30 centimeters of water during continuous chest compression at 90 per minute, delivered at 20 sustained inflation delivered over 20 seconds, followed by a pause of 1 second, keeping positive end expiratory pressure PEEP of 5 and 6. And this has shown that it doesn't affect mortality, but the return of systemic circulation is much earlier with this strategy. Another strategy is the chest compression with femoral occlusion. In a very small study, it has been shown that if you do femoral occlusion along with chest compression, there's less need for epinephrine, and there is increased coronary and cerebral perfusion, and the return of systemic circulation is much earlier. Well, we have to wait for larger studies. And again, in cardiac compression, the advice is to increase the oxygen to 100% to improve brain oxygen delivery. And indeed it does, but it is nowhere near the normal 6 to 8 mils per kilogram per minute. The best you can get is about 2 mils per kilogram per minute, even when you do 100% oxygen. So the gaps which we have in chest compression, the belief that only 100% oxygen enhances and improves myocardial function, and the likelihood of early return of systemic circulation is debatable. What is required is adequate coronary vessel oxygenation rather than 100% oxygen. That is the key determinant for successful neonatal cardiac resuscitation. However, what is adequate coronary vessel oxygenation is not known. Recommendation to initiate chest compression for heart rate less than 60 per minute is based on consensus rather than clear evidence. Benefit and harm of performing asynchronous chest compression when heart rate is less than 60, bradycardia, not asystole, on blood flow to the heart, lungs, and brain remains unknown. Should heart rate cutoff to initiate chest compression be the same for all gestation, i.e. for preterm and the term? Don't know. Now, yesterday overnight for me, there was a huge debate in the WhatsApp channel about epinephrine. Epinephrine acts on alpha-1 and beta-1 receptors as a vasoconstrictor and on cardiomyocytes to increase cardiac contractility to improve coronary blood flow. The current recommendations have been extrapolated from animal, pediatric, and adult studies, and only very few small studies in newborn in the delivery room, because the incidence is so very little that doing research on this is very, very difficult. But as it has now become routinely used, the equipoise for any research has been lost. The debate this morning on the WhatsApp channel was, what is the optimal dose? Well, to be honest with you, the optimal IV dose for early return of systemic circulation is not known. Recommended dose is from 0.01 to 0.03 IV every 3 to 5 minutes. Again, as I said, robust evidence is missing. Some guidelines give a range of 0.01 to 0.05. Hailing, in a small study of 56 infants, compared various dosage and suggested that the Optimal dose was 0.037 milligrams per kilogram. NRP recommends 0.2, PALS 0.1, and this is supposed to be based on educational efficiency. But actually, to me, it shows that nobody knows what the right dose is. But we do know that higher dose or more frequent doses, though associated with earlier return of systemic circulation, increase post-resuscitation myocardial dysfunction and mortality. The other debate was about guidelines recommended for flush, 0.5 to 1 ml of normal saline flush from low-lying UVC. Now the NRP is now suggesting, based on animal studies, lamb studies, a 3 ml per kilogram flush is better to achieve serum levels. And that may well be true, but again, it has been adopted from animal studies, and human newborn studies are scarce. But I think what is important is that we need to have a standard policy in your particular unit. And this is from Prem Valley's work, which is, I think it's a very good chart, which you should all be using. And they are suggesting labeled syringes, pre-filled syringes for various weights and various dosages. And I think that's a very good idea that units should adopt these. Lastly, and I'll just before closing, people after epinephrine, if they're still not successful, the guideline is to give fluids. Now, giving fluids when there is an actual fluid loss from bleeding, and there is hypovolemic shock, then of course giving fluid is very, very helpful. But majority of the fluid given in the delivery room is in euvolemic babies who have not lost fluid, and the main fluid which is given is normal saline. The question is that right? Because in euvolemic babies who are not being helped by positive pressure ventilation and epinephrine, because their cardiomyocytes are asphyxiated and the cardiac compression is delayed, the cardiac contraction is delayed because of the asphyxiated cardiomyocytes. And if you give them fluid, that may actually be harmful because it will overload the heart, which is already poorly functioning. So be careful when you are giving fluid in babies who are euvolemic. But it is extremely difficult to differentiate between hypovolemic and euvolemic babies in the delivery room. So the knowledge gaps here, questions as to type, amount, rate of infusion, and the assessment of response to volume replacement remain unanswered. I could not leave this presentation without mentioning sodium bicarbonate. This is an old paper which basically says sodium bicarbonate is basically useless therapy. The reason for that is because it does change the intravascular, but it also, because of the CO2, diffuses much more easily into the cells and into the cardiomyocytes. It causes acidosis, intracellular acidosis, which reduces particularly intracellular acidosis of cardiomyocytes, reduces their contractility ability, and the higher osmolality of sodium bicarbonate is responsible for the IVH. And so I think we have very good evidence that please do not use sodium bicarbonate in the delivery room. It is more harmful than useful. Apgar score, we all give Apgar score. It was described in 1952 by Virginia Apgar, but there are many, many questions. Subjectivity, observer variability, limited predictability, impact on resuscitation and interventions on the Apgar score, limited utility in the very preterm in the 27, 26 weekers, ethical and legal implications. Therefore, people are now moving away from the Apgar score. And if you read the literature on this, 1, 2, 3, 4, 5, 6, at least I know of the Apgar score, and their adjuncts and modifications have been developed. But I think the future lies in the voice and video recording, capturing real-time objective data in the DR, and that is what is going to be much more useful in determining the process of resuscitation in the delivery room. It will help much more in audit and quality improvement. But I think it is important that you should document clearly what you do in the resuscitation in the delivery room, because it may save your skin from litigation. So to finish off, Ladies and gentlemen, neonatal resuscitation practices are not static. They are constantly changing. And if you look at the variations between 2011 and 2020, oxygen delivery is not changed, but CPAP has gone up in the delivery of positive pressure ventilation has gone up. ETT, endotracheal intubation, has gone down. Surfactant use has gone down. The incidence of pneumothorax has gone down. So, to summarize what I have discussed in the last 50 minutes or so, in the era fueled by scientific research that is growing at exponential rate, we strive to assimilate the vast evidence available to provide best care to our patients. But please remember, most guidelines are recommendations, not the gospel truth, as some believe. Aeration, ventilation of the lung is the key to successful neonatal resuscitation. Increasing heart rate is the most important sign of effective resuscitation. Exact limits of hyperoxia, hypoxia in the newborn have not been established. Challenges remain in determining ideal timing of DCC, how much, when, and how to give oxygen, to start high or to start low. Inflation breaths, yes or no? If yes, what PIP, what duration? CPAP, how much PEEP? When to start chest compression and correct ratio, epinephrine or any other drug, use of caffeine in the DR, which I did not discuss, and the use of NERS in the DR, which I did not discuss. But remember, we need to learn, unlearn, and relearn all the time and be prepared to embrace uncertainty. Roshni Mahdood ho jinki in chiragon. Thank you so much for your attention.
Thank you, Dr. Haque. This was really wonderful talk, and I'm going to open the session for question and answers. Please, my only request will be, if you have a question, most welcome, but unmute, ask the question, and then mute yourself, so there is not much background noise. Please go ahead. Anyone has any questions?
Can I say it's an excellent talk, Dr. Professor? As usual, I don't have to say that it is excellent. It's as usual, excellent. Two things. The NRP recommend 3 ml of fluids, not 3 ml per kg, but the study showed the 3 ml. That's a huge thing, and I think you wrote email on that to Satyan also. So this is one of the confusion the people have. Just want to clarify this thing. The other thing.
Can I answer that one? And it is 3 ml, but this, as I said, the work comes from Satyan. It is the lamb in which he gave 3 ml per kg. So it is a very different ball game altogether, and we really don't know the answer, though NRP has taken up as 3 mils.
Yeah. Okay. The other thing is that now if you see the updated PALS, what they are doing, they are going away from any ratio. Once the kid is intubated, they said that you continue the chest compression and do the ventilation, from the TPs, or if you have bag and bag, that's fine. So there is no interruptions in the chest compression. We tried this in a few of the babies which are very, very sick and not improving. Again, there is no evidence. This is just observation that the kids did well after that. That if you continue chest compression, the chances of giving epinephrine is decreased. Do you have any? I know you mentioned about the asynchrony, but can you explain for all of us on that?
Look, the issue is, as I pointed out, there are two. Forget the first one, which I talked about cerebral perfusion. But the important thing is that coronary blood flow is in the peak of diastole. Cerebral blood flow is in the peak of systole. So there is a huge difference in when you are doing chest compression. At what stage are you doing the chest? Is it in the diastolic phase or the systolic phase? And therefore, the blood supply to the coronary blood vessels or to the brain will be differential. And we do not know the answer to that. And so people are, as I suggested, people are doing continuous chest compression and asynchronous chest compression. That is, you continue with the chest compression, you continue with your respiratory support without any break. People are still doing a 3-to-1 ratio. And so we do not actually have an answer. And the reason for that, as Junaid, is basically this, that the incidence of requiring chest compression is so minuscule, certainly in countries where research is done, that to do it in the delivery room, such research takes years, and to collect babies in any considerable number to do an RCT is virtually impossible now. And so people are just extrapolating from animal work and from mannequin work. So that is where we are. And that is, sorry, I do not know what has happened. That is where we are. And so I've tried to put to you the current situation, and that is where we are. And we don't know the correct answer. You can do what you think is right.
As I said, this is just an observation. I don't want to continue because I want other people to get the chance. If nobody, then I will.
I think we should give chance to other people as well.
Naila has a hand up.
Yeah, and I think Dr. Salman Ali has joined as well. Professor Salman Ali, he has some comments. Yes, Naila can go. Yes, sir.
Assalamu alaikum.
Wa alaikum assalam.
Thank you, sir. It was a very, very elaborative, and it gave me the answers of many of my questions. Yesterday, I was in a class and my student asked me, and I want to ask you that why the cutoff for compression is at 60 weeks? Why not 59, or why not it's 70 or 80? Even we were taking 100 as a cutoff, that if it is less than 100, it's not normal and it's ready. Why 60 for? I want to ask you, why 60?
I don't know the answer why 60. It was just chosen as consensus and expert opinion. By there is no reason why it cannot be 59 or 61. I have no idea. If anybody else has an idea, I'll be grateful. And as I pointed out, the heart rate of preterm infants is different than a term infant, and so why should it be the same? Because the bradycardic effect in a preterm infant occurs at a much higher heart rate than in the term infant. So we don't know the answer to many of these things. And that is the reason I gave it this talk on uncertainties, not necessarily controversies, but uncertainties. We are uncertain about many things. And unless we challenge the uncertainties, so as was the discussion this morning, I thought some younger people were absolutely adamant on the number and whatever, and believed in the guidelines as if they were gospel truth. That is not so. Dr.
Thank you, sir.
Dr. Jarala.
Yeah. Thank you very much, Doctor, for this excellent talk and excellent, presentation. I think neonatal resuscitation should go and should be tailored to a specific condition. As you mentioned, I think not one fit all. So I think this protocol and the resuscitation should be based on the clinical. So a patient with a cardiac anomalies, for example, or asphyxiated baby or a preterm baby, I think every resuscitation approach should be differ based on the clinical presentation. But I see now every recommendation and every review of the NRP or, American Academy of Pediatric or European Consensus Council for Resuscitation, they have the same protocol for every condition. And now we are going to precise medicine where every individual, every station is different. What do you think?
I fully agree with you. I think we have to understand that these are guidelines. They are recommendations, and we have to adapt them according to the baby, according to the condition, and according to the resources we have. And I think that is important. But these guidelines give you some marks, milestones, where to start or what to do. And so I fully agree with you that we need to adapt them. But there are medical legal reasons, particularly in North America, there are medical legal reasons, because if they go even slightly off the NRP guidelines, they may face litigation. So there are many other issues which are not scientific, but I think they have to follow them because that is important for them.
Can I jump in, Dr. Rashid?
Sure.
Dr. Khalid, it was a wonderful talk. Couple of points, and I think you were there when we were having the discussion about epi-dose and all those things. The answer to the question that was posed by Naila about the heart rate of 60, actually there is no evidence. I could not even find one. I'm sure you did not find one.
That's what I said.
Yeah,
what I
that
said.
number, where the number 60 comes from. So I think it is something that we are now stuck with until we have some more data, which obviously is impossible. But the important thing that the previous person that was raised a question, I just want to clarify one thing, that the reason for having an NRP and not tailor it according to a specific condition and according to specific scenarios and everything is because NRP, if you run a resuscitation code, it is run with a team. And the team comprises of a physician and nurses and nurse practitioners and respiratory therapists, especially in the country that I am in. And whereby if you have different of opinion about should I start compression at 59 versus 64 versus, like tailoring according to the specific condition, then it will create so much conflict in the delivery room, whereby performing it as a team step, like a team work, it will become very incoherent and chaotic. So that is those are the two things. But in terms of the oxygen, Dr. Haque, you presented so much data and everything. Where is your personal opinion on oxygen? What do you think is where the oxygen should be a good number? Like, I'm not saying it is hard and fast, but what do you think?
Two questions and two answers to your first question. I think where you are practicing in the United States, you have no choice but to follow NRP for medical legal reasons. You have the luxury of a team which can look after various other things which are going on. As you wrote in your WhatsApp message, your nurse would not allow you to change the dosage of epinephrine, for example. But we are talking globally. We are talking also about low and middle income countries. I think each guideline, and if you read these guidelines, there are about 9 or 10 that I have read, and each differ according to their own requirements and resources. So let us be upfront. Yes, your guidelines for your country, very good. Use them, work them, but don't make them universal and say this is what will fit everywhere. One size does not fit everything. That's number one. Number two, about oxygen. I actually believe very firmly. Now, I'll tell you why I believe that, and I'll come to give you the answer. When I started doing neonatology, which probably I don't want to give my age away, but I have done it for nearly 55 years of neonatology. When I started doing neonatology, there was no choice. It was 100% oxygen. And we saw a lot of problems, but we also saw a lot of good outcome. So I have seen that era, but also when much later in life, I realized and started looking at when the guidelines started coming, and we started using lower and lower oxygen requirement. But 21% oxygen is good for term and near-term infants. I do not know what the ideal oxygen, as I presented in my presentation, what the ideal or optimal is the correct word, optimal oxygenation to start off with in preterm infants. I really do not know. And my guess is as good as yours or the next person. And I cannot if somebody says 30% and somebody says 40% and somebody says 60%, I cannot, what I have shown is that between 30%, 21% and 30%, there is no difference in mortality. Between less than 40%, more than 40%, there is no difference in mortality. Above 60%, Julie Wu's work shows that the targets are achieved much quicker. So I think the answer would lie somewhere between 60 and 100%, but I do not know. I have no answer to your question because the data is not there.
Assalamu alaikum, Dr. Haque. Does you hear me, sir?
Ji, I can hear you.
Thank you so much, sir, first of all, for a very hot topic discussion over this group. And this was, as usual, wonderful. I have two questions, sir. You have mentioned that they have done a RCT in which they have, taken 3 groups with minimal, moderate, and higher oxygen saturation during resus. So I just have 2 questions. Did they follow the incidence of ROP in moderate and high oxygen groups? And did they exclude cyanotic congenital heart disease if they were antenatally diagnosed or not? So these are my 2 questions because I'm really concerned about these 2 things. And high and moderate oxygen groups?
Today, I didn't understand your second question, but the first question is, the answer is yes. They have done the initial high oxygen and then brought it down rapidly, and they have done the follow-up studies, and there is no increase in ROP. But remember, this oxygen was given for 60 seconds and not anymore. It's 100%.
Fair enough. Fair enough. So the second question is for antenatally diagnosed cyanotic congenital heart disease as an drug-dependent region, DTGA, or chaos with impact sector. With severe pulmonary atresia. So did they excluded those babies?
No, the data does not excluded babies who were antenatally diagnosed to have cyanotic heart disease.
All right.
The physiology is very changed in these things. The other thing, sir, about the oxygenation, the first thing about the heart rate, there are few studies, very small studies I will share with you, and they found it out that 60 to 100, most of the time babies are cured by the positive pressure ventilation if you are doing a very appropriate and doing everything appropriately. So that's why the number 60 came. Now, why not 50? According to that article, I will send it to you, inshallah, for everyone. They said that it is too low for the perfusion for the brain to wait that thing. So I think this is old study. This is, started saying that 60 is somewhat ideal. Of course, there is robust evidence is lacking. We don't know, but this is the answer for that question, which people are asking, that why 60, why not 70? Because 60
hold on, Junaid. That is an old study. I've got it. It's a term near term inference. The question is, should it be 60 for a 28-weeker? Should it be at 60 for a 30-weeker? We don't know the answer.
We don't know.
But the guidelines are just give you one figure, 30, 60 or less.
That's good.
So that's the point I was making.
Yeah, thank you very much. I think Dr. Naveed Durrani has two questions. He's from Qatar. Dr. Naveed, you are there?
Thank you, Dr. Sajjad. Thank you, Dr. Professor Haque, for such a nice lecture. I have just put two questions in the chat as well, that most of the babies who have congenital anomalies like gastroschisis or congenital diaphragmatic hernia, cyanotic heart disease, they are excluded from all those studies. So extrapolating these data to do the delayed cord clamping in such babies till the more robust evidence comes should not be done. What do you think?
I would send you the studies which actually show that DCC in critical congenital heart disease and diaphragmatic hernia delay is acceptable and is better.
But the problem is, unless you don't have a life start trolley and you establish the FRC, it is quite dangerous that you are delaying the 1 minute for especially the CD.
I would respect your opinion, but I would like to differ with it.
And the other thing is that about the twins, triplet, and quadruplets, that's a thing that we are not doing the delayed cord clamping in any of those things. This is one of the.
In my knowledge gaps, I pointed that out. That, do not know the twins or quadruplets. I pointed that out.
I think Dr. Abdul Hamid was asking about the recording of this excellent lecture. Yeah, this will be posted in the group, inshallah.
Dr. Jarallah has another question, I think.
Yes, Doctor.
Yeah, I have a comment actually for Dr. Junaid regarding the 60. Recently, we have a patient born with heart rate of 50, and it turned to be congenital heart block. And the baby was fine, and discharge home with 55 heart rate. And the baby was really pretty fine. So number 60 is really just, nobody know from where this has been chosen. The other one for the diaphragmatic hernia, I recently was in the past meeting, and they were really discussing, and there was like an approach to deferred cord clamping for baby with congenital diaphragmatic hernia. There is ongoing trials, but I think the delay, 60 minutes for a baby with congenital diaphragmatic hernia will not make any difference, if they are delaying the cord clamping. And also for the IUGR babies and babies with multiples, I think studies going on, but I think it's the normal to have a delay cord clamping, even for those babies. But we will wait for further trials.
I fully agree with you. I think, as I quoted that, a 30-second delay or a 60-second delay, would it matter in a baby who has been in utero for 9 months with diaphragmatic hernia or with critical heart disease? I mean, that's just because people have just put it there. But I personally, I agree with you.
Jabara is our leading academic neonatologist from Saudi Arabia. Thank you very much, Dr. Jabara, for joining us.
Thank you, Dr. Sajjad.
Thank you.
Any other questions from the floor?
I do have a comment.
Sajjad, can I say something?
Yes, go ahead.
Yes, Dr. Sajjad, please.
And lastly, when we were having these lectures, we were posting them on a YouTube channel, and most of them are still on that channel. I just want to say that if we still have access to that channel, so everything is being saved in one single place, and मैं या कोई भी और छोटा हमारा पढ़ना चाहे या सुनना चाहे तो सारे मिल जाएंगे. तो ये था मेरा मतलब पहले तो हमारे इंडस चैनल को अभी चाहिए होता है.
Please speak in English. Yeah, please speak in English because we have got people from various languages here.
Okay. I just wanted to say that we should keep these lectures in some YouTube channel. Maybe we can make a new one, or maybe we can put these to the old one, which still have that asset of the previous lectures.
Yeah, so let me answer this question. So all these lectures which we are doing monthly under academic neonatology series, we are recording them and we upload them after editing them, some, the background noises, etc. And this lecture will also be uploaded to the channel, inshallah. And the previous one, which we were not able to upload, the one journal club, which we did, and I'm working on it. So hopefully that will also be uploaded in next few days, inshallah. And I just have one quick, Dr. Naila, do you have any other comment? Sorry.
No, I just want to know what is the channel? Is it a YouTube channel?
It's a YouTube channel. It's APPNA Peds YouTube channel.
Okay. Thank you.
And I have a comment, and Dr. Khalid, this is really amazing discussion which we had. My comment is that I think the NRP, and this is my personal belief, that the NRP's focus was mainly to having the resuscitation team on the same page. And their belief is like, having resuscitation team on the same page will bring better outcome versus if you have everybody thinking differently during the resuscitation. I think that kind of purpose actually trumps everything, and they have to come up with something so that everybody is thinking in line during that panic mode. And for example, they're not thinking, okay, we should give 0.01 dose versus 0.03 dose, or we should actually start chest compression at 60 minutes versus we should start at 90 minutes. So they basically, their main point was like the team should be thinking same and should be on the same page, and that would have better outcome versus if we don't have it. How would you comment on that?
Absolutely correct. And that is the very reason why we have created the Pakistan Neonatal Resuscitation Manuals, so that in Pakistan also people are on the same page when they go to the delivery and attend resuscitation. And that is why I think it is important to have, and I know that Saudi Arabia has one of its own, and so there are many countries have their own resuscitation programs and manuals, but these differ slightly in context and things, but the resuscitation process is virtually the same. They may differ in little nuances, but yes, indeed, that is what it should happen, and that is there should be guidelines in all hospitals for everything which they do. For example, antibiotic policy. There should be a guideline for antibiotic policy depending on your local bacterial spectra and your antibiotics availability. So similarly, there should be resuscitation guidelines which then you should follow so that everybody is on the same page. And NRP is wonderful for America, where you have that luxury, where you have so many people in the delivery room. In Pakistan, for example, you'll be lucky if you get more than one.
Dr. Khalid, kindly allow me to ask one more question regarding Pakistan guidelines for neonatal resus.
Yeah, Safdar is the host, I'm not.
No,
My question is, thank you so much. For these guidelines to be developed by either this is NRP or NULES or any other guideline, there has to be some data in your hand. What is my personal perspective that in Pakistan, we do not have any local data. Even in the biggest centers of Pakistan do not have any data of NRP resuscitation, sorry. The word is resuscitation of the neonates. So what is the basic, tool for these guidelines in Pakistan that we have been talking about in recent past? Can you please throw light on that?
True. The data is scarce, but we chose people from all the provinces and they produced their own unit data, and our guidelines are based on data provided by 9 different people from different parts of Pakistan. They may not be as robust data as the ILCOR or NRP data, but that's the best we could do in Pakistan.
So is it published, the data is published, or it is just collected for the purpose of developing these guidelines?
No, the guidelines have been developed and they are available, and I have sent you. They should be available to you too. I have sent the copies to Dr. Safdar. I don't know whether you received it or not, Safdar.
I have not received it yet, but
no, I posted it last week, so it should be with you today or this week sometimes.
Okay, I check my mail probably once a week. I will do that today.
Sir, actually, my question was regarding the data which led to the availability of these guidelines. You talked about 9 different centers who provided you the data of resuscitation. So that data is published, or they just provided for the sake of developing these guidelines?
They were provided for developing these guidelines.
All right.
I think Dr. Aisha Munir has a question.
Thank you, sir.
Yeah, Dr. Aisha Munir has a question. Is she there?
Yes, thank you, sir, for the excellent talk. I just wanted to ask if you could elaborate a bit on the duration of the CPR. Usually the guidelines, they recommend to, once the chest compressions are started, to run the code for 20 minutes. So I just wanted to ask your take that obviously we stop after 20 minutes, but at times, especially once epinephrine has also been administered, you have a faint heart, and a lot of people in the team who are there, they're reluctant to call it off unless there's a straight line. So, and many times we do see that if we run the code for an extra 5 minutes, 10 minutes, maybe 20 minutes more, in 40 minutes, the babies do come around. So these 20 minutes that are recommended, what's your take on it? That's all I wanted to ask.
Sure, good question. My take on it is that beyond 20 minutes, the neuronal damage is quite significant. And so, yes, there are some studies which have continued the resuscitation beyond 20 minutes, but nearly all of them suffer from significant neurocognitive problems. And the mortality is also high beyond 20 minutes. So 20 minutes is a line drawn where most people recognize that neuronal damage is going to be very, very significant beyond that period. So yes, there are babies who survive if you continue resuscitation for longer than 20 minutes, but the outcome is very poor. So it's a question of balancing between successful resuscitation and not so successful resuscitation as far as long-term studies are concerned.
Right. Thank you, sir. That clears a lot of things. Thank you.
I still have Dr. Jalala's hand raised. Dr. Jalala, do you have another?
Yeah, Dr. Jubala. So maybe one last comment about uncertainty. NRP and null NLS is a delivery room station. If you have a baby in the NICU, still there is uncertainty. Some centers, some hospitals, some country, they do NRP. Some center, they do pulse. So still one of the uncertainty, what to do for the baby beyond the delivery room?
Very good question. In fact, that is one of the things which we have included in our manual, resuscitation manual, which was not present in many other manuals. But you have to, Dr. Jarala, you have to decide one way or the other which one you want to use. And so the NRP is basically more geared towards the delivery room. The environment in the NICU is very different, and the facilities available in the NICU are very different, and the basis in the NICU are quite different, because you often know the pathology which is going on. The baby has transitioned already from in utero to extrauterine life. So there are huge differences in resuscitation in NICU versus delivery room.
Yeah, what we are doing depends, on the centers, and like if your staff is already like have skulls in the NRP, so which is I do agree, all the NICU nurses, physicians, they are qualified for NRP, and most of them they don't do like pulse regularly. So I think safe at this point. There is no really consensus to that, and the unit who's doing NRP, they are continue. While, for example, in Brazil, after delivery they do pulse for their babies, but all their staff, they are pulse certified. So I think look to your environment, look to your staffing, look to your center, what do you have, and put, as you mentioned, guidelines, what to do even after the delivery room, resuscitation beyond the delivery room. And keep in mind what is the underlying disease for this arrest or the need of resuscitation. It's just a comment. Thank you.
I couldn't agree with you more, but except if I give you an example, a 5-day-old neonate crashes in your NICU. His lungs are full of air. In delivery room, the baby's lungs are full of water. Are you going to use the same strategy?
I think that's a very important question. Okay, can we invite some comments from Professor Salman Ali?
Okay, thank you, Professor Sajjad, and Assalamu alaikum, Professor Haque.
Assalamu alaikum.
Thank you very much. I joined a little late because of net problems, but I fully attended your lecture. It's always a pleasure to really listen to Professor Haque. I think you have raised a number of questions, and you have really stimulated the brains of all these attendees to really think about their practices, and whatever we are practicing, still we should raise questions about these practices also. So I think that is a very, very useful message. It's always a pleasure to listen to your lectures. But having said that, I think being in Pakistan, we have been attending deliveries for so many years, but the key for entry into the delivery room in Pakistan lies with the gynecologist. And if she opens the door and allows the neonatologist and said you are in for resuscitation in the delivery room. If you are not allowed, somebody else might be resuscitating. Maybe the gynecologist, maybe the anesthetist in the operation theater. So what I think is we should expand our neonatal resuscitation, this forum, and open it to obstetricians and anesthesiologists also who are involved in neonatal resuscitation practices. And I think the Pakistan manual, which is lying with me here, somebody asking the question, the manual of neonatal resuscitation for Pakistan, it is here. This is this is authored by Professor Haque, and I think it's very useful for our neonatologists in Pakistan practicing in resource-limited conditions. So the message for all is that although people are listening to lectures on neonatal resuscitation, but the entry of neonatologists and pediatricians into delivery room is essential for saving the newborns in our setup. Unless we attend the deliveries and welcome the newborns with our own hands and with all the resuscitation practices, the mortality of neonates in Pakistan would continue to be, high, and we will remain discussing what to do about these newborns. So I think we should open our delivery rooms to neonatologists. There was a time when medical students were not allowed into delivery rooms in very conservative conditions. I mean, Professor Sajjad is a graduate of Khyber Medical College. We know that their graduates would be attending the gynae session or the delivery room session, delivery room duties, they would go to either Dover Medical College, Karachi, or to King Edward Medical College, Lahore. So the reason is because the males are not allowed to enter the delivery room. So these are some of the, cultural peculiarities which we face here. So, and these are not mentioned in our actual practices. I mean, in our actual guidelines, these things are not mentioned. But on the ground, the neonatologist, the pediatrician, anyone who goes for resuscitating the new neonate, I think these sensitivities have to be addressed. And overall, but I have seen over the years of my practice, there has been a tremendous advance and understanding of neonatal resuscitation practices. And we have come to a stage where we have got our own guidelines in Pakistan. And I think we should move forward from here. And your today's lecture has really stimulated everybody to really review their practices and see that whatever we are practicing, have we got an evidence for that, or we have what we are to do, what we are to suggest. I mean, we need more research on this. And I think many of our trainees who are doing projects on research, so there is a lot of topics which we can give them. And I think in your lecture, you have raised a lot of gaps in our knowledge, which we need to address and which we need to rethink. So thank you very much for really this wonderful lecture and really making this evening, Sunday, really knowledge-wise, enriching us and making us think for the future. Thank you very much.
Welcome. Thank you, sir. Thank you.
Semin is raising her hand.
Yeah, we do have 10 minutes, but I see there are some comments about...
Dure Semin again. Dure, go on.
Assalamu alaikum, Dr. Khalid. This is not your classmate, but
very good colleague and very good friend. Yes, mashallah.
That's right. Yes. So wonderful lecture. I really enjoyed it. I listened to it with great interest, although I'm not a neonatologist, but learned a lot. My question was regarding your involvement with neonatal teams in different parts of Pakistan. Are you involved in doing research? We've got so much material and wonderful neonatologists here. Are you involved in producing data from Pakistan related to the gaps in knowledge that you have mentioned?
Notice, I mean, I have tried my best for the last 30 years. It is easier to get water from a rock. It is really very difficult. I have written protocols for them. I have given them topics. I have given them ideas, but nobody comes forward. It's very unfortunate for us that we have so much data that we could collect that data within a year, which will take people in the West 5-10 years to collect.
Exactly. Yeah.
We just don't do that. I feel very sad about it. I feel very disappointed about it, but that's the reality.
So perhaps the APPNA team can kind of act as a catalyst for the future. There's always hope.
Anyone would do. It will be a great service to Pakistan.
Thank you. Thank you for your talk.
Welcome.
Uzair Hussain has a question about surfactant. Is Uzair here or left?
So I think we
Dr. Uzair was asking a question. Maybe he's left.
He's here. He says on the chat, he says he's here.
He's here. Can he raise his question? Uzair Hussain, I think he has probably left.
He has a question about the surfactant in the delivery room.
Surfactants.
Yeah, I mean, we'll come to surfactant and other things. Yes, there is some evidence that it can. The earlier you give it in the selected babies, in the high-risk babies, yes, the better it is. But this talk was not directed at using surfactant. There are so many other things also. And for example, caffeine. I did not discuss that. For example, NERS. Now there is a lot of work whether NERS should be applied immediately or not. There are so many things which I did not discuss. There is not enough time to do all that.
Amir Bashir from Missouri has a comment as well. Dr. Amir Bashir is here, or he has left. Okay, right. Yes, Dr. Safdar.
Yeah, I think we kind of going to wrap up everything. I think we will continue our monthly lecture series.
Thank you so much, everyone.
But thank you so much, everyone,
Thank you for attending the lecture. I'm very grateful for all the questions. They were very thought-provoking and very nice. And I hope my lecture was of some use to you. Thank you.
Okay.